Hello, everyone. This is Chris Frederick with the Collaborative Care Network, and I'm here with Dawn. And Dawn, I don't even know how to say your last name. I don't want to mess that up.
That's fun. Nobody does. It's Sandalcidi.
Sandalcidi, I love it.
Sandalcidi.
Um, I'd
Mhm.
like you to talk about your profession and specialty, any
Mhm.
special credentials, and the types of patients and conditions that you treat, if you don't mind.
Yeah.
Let's start with
So
that.
I'm a physical therapist um, for coming up on 43 years now. And my career has taken me all over from starting out in hospital inpatient care was kind of required when we graduated back then. And then I traveled, which was just a beauty. I traveled to Germany and worked with Hans Dietrich Wolf, who
Mm,
made learn from. And he was an osteopath in Trier, where I lived. So I got to spend some time with him. Not a lot, not extensive, but got to spend some time with him. Really got my interest going in manual therapy. And then I heard that manual therapy was really well utilized in Switzerland. And I wanted to ski the Swiss Alps. So I went
mhm.
to Switzerland after I learned how to speak German in Germany. And I was in Germany a year, then I went to Switzerland for 2 years, and I got my Maitland certification in Switzerland. And then I was in a McKenzie course, and it was a Swiss guy teaching the class, and he worked for Brian or Robin. Sorry, I get my Mackenzies mixed up in New Zealand. And
Right.
and he worked for Robin, and he said, "What's an American doing in Switzerland?" I said, "Well, I came here to do manual therapy." And he said, "Oh, if you want to do manual therapy, you need to go to New Zealand." So I did. So I wrote a letter and got a job in New Zealand and visited Robin McKenzie in his clinic. When I travel, I like to visit different clinics and hospitals just to see how things are done differently than what we.
Hmm.
And he said, "You need to go down to Christchurch and meet with Brian McKenzie." And so Brian, Robin, and Stanley Paris, all Kiwis, and they all started the manual therapy program in New Zealand. So I went down to see Brian, and he said, "Well, I'm actually hiring if you're looking for a job." And I had a visa to work as a physio in New Zealand. So I went to work for Brian McKenzie in New Zealand. And I did a lot of sports medicine. We took care of the Canterbury team of the All Blacks, and then there's all the rugby is huge, obviously, and cricket.
Hmm.
So
Hmm.
my colleague Marg, she took care of the cricketers, and I had like 30 some rugby players every Monday morning sitting outside the door waiting for me to get. And we saw a lot of patients. We didn't have documentation like we do in the United States. And so we had like a 3x5 card. We just kind of put their name and kind of, a little bit of what we did. That was it on a card.
Wonderful.
Um, and then we had people called what we would call um, athletic trainers. They were called phys editors, and we had a big gym. And yeah, I learned nags and snags in the gym in there, a casual before it ever came out. And this was back in the early 80s and mid 80s. And so I had just this amazing experience. Those are the days when somebody fractured a rib, you just taped them and put them back in the game, because if they didn't,
Yeah.
they were off the team.
Yeah.
And it's more organized now than it was in the 80s. So it was just really different. And so I got a lot of great experience in New Zealand with manual therapy. Unfortunately, was hit by a car on my bicycle on my way to work one day
Oh
and
boy.
sustained multiple injuries. And I just felt like I needed to come back to the US for care. And so that
Mm,
was the reason I left New Zealand in 1987 or 88, I think. 87. And so there and actually that my head hit the windshield, and
oh,
I ended up I have 26 screws and 4 plates in my face. And
oh boy.
so I became very interested in jaw issues. And Then I
naturally.
did the whole Rockabato program and became an instructor for Mariano Rockabato. And so my primary focus when I came back to the US was orthopedic and jaw, head, neck, and facial pain. And I saw how people were treated in the 80s in Colorado and wasn't too excited about how pec ultrasound and massage and
All
the
right.
exercise. So I started my own practice. So I started my practice in 1989 and I had it all the way up until 2023. So many years in private practice. Was the first private practitioner to go cash in the Denver area and first to become a pelvic health specialist. So the private practitioners asked, we were organized in a group and there was physicians doing pelvic health and they said, Dawn, your practice has the least number of visits with the best outcome measures. So can you do pelvic health? And I said, no. I said, you want me to do what? And so I didn't really want to do it. And then they said, we're going to pay for you to take a class. And there's one in Keystone. And one of the docs I worked with downstairs, she came with me. She was family practice. And I said, what's a detrusor and what is mectrician? And I knew nothing. And so I went to this conference and I thought, oh my gosh, these women really suffer.
Yeah.
They really suffer.
Mhm.
And so, fast forward, I took all the classes at the time was through the APTA section of
Mhm.
women's health. And my first patient was a male and we learned nothing about men. So I remember
Mm.
a moment saying to my husband, I need to see boy parts like differently. So I learned about male anatomy, kind of self-taught, and this man was going through 6 diapers a day after a prostatectomy.
Oh,
So this
oh boy.
practice then sent me, after he got better, they sent me a lot of patients. Then one day, one of the urologists called and said, Dawn, get this kid out of my office. I'm like, what's wrong with kids? What do you mean? They haven't had babies, I don't know. I don't know. So it's so new. And so he explained to me what was wrong with kids. And it was fascinating. So I went and watched him operate, and the kids have vesicoureteral reflux where the urine backs up into the kidneys, and it can be fatal if it's not. I mean,
Yeah.
this kid that he sent me, the first one, was on a kidney transplant list from 2 failed surgeries. And the surgeries failed because the pelvic floor wasn't treated.
Mm.
So I developed an entire program for pediatric pelvic health, which I
Goodness.
do today because there was no courses, there was no information. This is like early 90s. And it's really been so fascinating over the years what I've learned from adult and children pelvic health problems and how that
Hmm.
relates in the pelvic girdle and and the rib cage and the diaphragm, and it all comes together.
Hmm.
And it was 2012, I think, that I took Diane Lee's course of the integrated systems model.
Hmm.
It was life-changing.
Yeah.
It was really career changing.
Hmm.
And learn to just this integration of all of these parts and how that all works together. And I use this model in every patient population. So
Hmm.
it's phenomenal. And then I was at a lecture at the hospital nearby, and Dr. Tim Mazzola was speaking. And
Okay.
in his lecture, he said,
Hmm.
yeah, we're always injecting the rec fem. And so I'm a little bit of a quiet person in the background at a lecture. So the end of the lecture, I said to him, do you know why you're always injecting a rec fems? And he said, no, why? I said, because you got a failed load transfer. The femoral head is anterior and it's not seating. He said, tell me.
Hmm.
And
Hmm.
then came down to my clinic, watched me work. And that was, I don't remember what year, it's been a long time.
Hmm.
Yeah, early, mid to 2015-ish, somewhere.
Hmm.
So at least 10 years. Yeah, I think it's got to be at least 10 years now. And so we just started collaborating and collaborating
Uh,
and collaborating more. And so it's been such a learning experience for me. And just to see where my career started and orthopedic, manual therapy, and then I did all of the Burrell training. So when I
mhm.
went to Diane's class, it was in Canada, in Vancouver, and Gail Wetzler was my lab partner.
Oh,
We sat
goodness.
next to each other, and it was 3 weeks long, 3 separate weeks. So we got to reconnect and reconnect and reconnect. And then I got really interested in the Burrell program. So I finished the whole visceral mobilization series with listening. And so I did all of that. And so it's been, a 42 plus year career.
Hmm.
And I love it as much now as I ever did. Um, I sold the practice and moved up to the mountains because that's where I was living half time. Now I'm here full time and I have just mountain peaks all around me and love it.
Great.
But I'm not retired. I still work. And I
Mhm.
work at Summit Pelvic Health up here in Summit County. And I have some patients of Tim's that will drive up and see me up here. It's about an hour and a half away. And and I see kids and I mentor the therapists up here, which I just love doing. I love
Mm.
that. Love mentoring.
Well,
So
that
that,
explains how you got involved with the Collaborative Care Network, which we like to fondly call C3 these days.
yeah, the collaborative care collection.
Collect,
Collection?
collection,
Yeah.
collective or collective.
Collective. Yes, I don't know what I'm. So yeah, it's been, so Tim just, it actually, there was a meeting of the minds group of a group of regenerative medicine docs across the country. And that's where I met Dr. Steele, Dr. Fullerton, and I was the only physio. Tim invited me to be in that group. So
Wonderful.
for 2 or 3 years, I got to listen in and learn about regenerative medicine. And they were always interested in my input. This group of doctors are so amazing to work
Hmm.
because they want to know more. It's never enough. And last year, I mean, I've been up to Phil's clinic in Montana. He's been down here many times with Tim. And then when he comes in, I usually go up to Boulder and hang out with the two of them. I still go down to Boulder to see Tim's patients with him. He has evaluation days, and so I evaluate with him. So we just kind of do this, frickin' frack. We just keep
Yeah.
we look and just like, what about this? What about that? Let's look over this. Let's look at this. So it's really fun because we just, we our collective minds, with coming from different backgrounds, have created this immersion of curiosity.
Mm.
And so we get curious about so many things, and that this path of curiosity is growth and learning
Hmm.
things I never would know. And I can look at an ultrasound and trust me, I can't see a lot. But now
Hmm.
I was down there a couple months ago and Tim said, I said, is that what we're looking at? He goes, yeah, you got that, Don, you got that. So I'm starting to see things that I didn't used to see before and
Let
see
me,
from how he's looking at them.
mhm. Let me ask you, this is an incredible story. It's very inspiring to me. All the pioneers and all the names you dropped, uh, professionally speaking,
Mhm.
are people that I've always looked up to, and I'm very familiar with all the greats of manual therapy that you actually trained with and studied with, which is I studied with some of them, and it's admirable. And then you coming together with physicians is to me a little more rare these
Yeah.
days, or it has never been very common. And
Yeah.
so I'd like to dig a little deeper into that because it almost seems like the ideal way of doing things. I'll never forget having a fellowship at Rusk Institute in New York City as a pre-physical therapy student. I got this fellowship and I sat at a table with everyone collaborating. And I
Mm.
thought this is the way it always is. I sat
Wow.
there with the top, with all the physicians, the psychiatrist, the psychiatrist, the social worker, everyone on the team. And I thought this is the way it is. And it's really not like that all the time. I was very fortunate to actually have a collaborative care collective right there.
Yeah. Mhm.
And then everyone's kind of on their own, and physical therapists just kind of work in the PT department. In a hospital, we did our rounds. Other than that, and then I went
Mhm.
into private practice and worked in different private practices, and that was that. I never really got to see another physician to collaborate. And we're talking the complex patient, right? When you have not not everyone anyone has the one answer, and I think
Right,
that's what we're talking
right.
about here. You are so fortunate to be part of this beginnings of C3, really. You did this almost your whole career, increasingly so more recently. And now we
Right.
have the collective of all those people you just mentioned are part
Mm.
of C3. And anyone who wants to come to the summit June 27th this year, 2025, can meet everyone, listen to the presentations, and take some laboratory with them as
Yeah.
well. So I think I want to ask, the patient story is like the centerpiece of our philosophy, isn't it? Um, can you speak just a little bit on the patient's story and what that means, how it informs your evaluation and treatment, and certainly when you collaborate with others, it all comes in.
I'll never forget, I was at a lecture that Paul Hodges, or no, I'm sorry, no,
Hmm.
Peter O'Sullivan was giving, in California. And, and it was funny because he lived and worked in New Zealand, and I said, "Where did you work in New Zealand?" He goes, "I worked for Brian McKenzie." And he looks at me, he goes, "Wait, you're Dawn?" I'm like, "Oh no." He goes, "I took your job when you left." Isn't that so funny? What a small world. But
Hmm.
Peter, O'Sullivan said in this lecture, he said, when a patient comes in, I want you to visualize yourself with something to drink and popcorn, and sit down and get comfortable and listen.
Hmm.
Never forgot those words. And then Diane Lee reiterated that about
Hmm.
listening to the patient's story. And I always tell the younger therapists that, or students I've worked with, when you listen to your patients, they will tell you what's wrong with them. And just really listen, let them tell their story. And you might guide a few questions about where, and let's go back to, and before that, did you ever have, a fall? Did you ever, a concussion, things like that. Um, and when you really listen, you hear so much, and your brain
Yes.
starts formulating more questions.
Yes.
Instead of formulating, you've got to do this, and this, you formulate another question.
And they don't do that in the system. A doctor has 5 to 15 minutes if you're lucky,
Mhm.
and the system does not allow for that, and so much gets missed, and lots of things
Right.
are misdiagnosed, and they have to fit a code as opposed to fit the individual of what's really
Mhm.
going on. So I think people like you, and there's not a lot, independent practitioners and those who have bucked the system don't really work with the insurance system because it constrains everything.
Mhm.
They're forced to do that. They want to treat as many people as possible, but pretty much have gone the private, cash-based system because insurance doesn't allow for the way you want to practice and listen to the patient's story. Isn't that true?
It is, and I find it really sad because the majority of people can't afford it.
They can't. Yeah.
Our healthcare is insurance driven, and as a new Medicare recipient, I,
Yeah.
I am learning that an annual physical with a doctor is not to have a physical. It's just to say, okay, these are your medications. Good, we're all set.
Hmm.
I'm like, do you do a breast exam on a physical
Yeah.
before, or um, it's insurance driven.
Yeah.
And I'd love to be able to provide more. In fact, we have a grant that we've gotten up here in Summit County for people that can't, because am in a cash practice here as well. And
Mhm.
people that really need the services but can't afford them. We've worked with a group of physicians, and the owner, who I work for, I love not being the boss. She's phenomenal. And Quinn Griffin, and she is working on this grant that to provide support for patients that need extra
Wonderful.
help.
Wow.
And so we work with the community health services, so we can get kids treated and that need to be treated and so on.
Well, I think you and the others you mentioned, the others who will be speaking, the doctors you collaborate with, the physios like Gail Wetzler and others will all be speaking. They and my practice has been the same too, where I got out of insurance, and it's so much better. You have the time to work and really listen to people and actually help them get better together as a team. And I think we will inspire those who attend. I think if you're listening to this interview, you are able to rub shoulders with those who are actively doing practices that they actually love to go to. It's not work, it's a passion.
It
And
is.
because we have the time to do what we really need to do, and the patients benefit and they love us and we love them,
That's
it's
right.
so different from what's out there. And if that's the only thing, come to this summit because it's so inspiring and you will change the way you practice. And if it's not now,
No.
you will meet the people who maybe you can work with in the future. So I just want to toss that out there because, people need hope. The practitioners need to know where to
Yeah.
go, who to
Mhm.
find, who to speak to. So what are you speaking about at the summit?
So one of my favorite things to speak about is the diaphragm. And so I'm also doing a keynote lecture on the diaphragm for Herman and Wallace for their annual meeting in March. And the diaphragm is just so fascinating. And we need to have pressure system control in our body for the body to work.
Mhm,
And we see so many patients with, we'll talk about rings and how we get ring dysfunction and, the third, fourth ring, or, it could be high up, it could be lower down. And knowing some of the anatomy of the core and the transverse abdominis interdigitates with the diaphragm at the lower six
mhm,
rings. So we
mhm,
have direct connection from the deepest core muscle to the rib cage. I remember Paul Hodges saying, I was at the World Physiotherapy Conference. I did a lecture there in South Africa. But I think this lecture was in Geneva. He said, he talked about ribs and that how things get missed. So many people ignore the thorax and it was just really encouraging us to, I was an ultrasound course and we were looking at, I use ultrasound a lot in my clinical
mhm,
practice. And I can look at the diaphragm on ultrasound and see how it's functioning. And if the rib angle is wide, or if there's, I call it a posterior rotation of the
mhm,
thorax. Um,
mhm,
because basically, if you think of the pelvis anteriorly and posteriorly rotates. Well, if your ribs are not directly aligned and stacked with your pelvis, then they could be anterior rotated or they could be posteriorly rotated, right?
sure.
And then it changes rib position, that changes activation of the transverse abdominis, it changes fascial connections around the back to the lateral raphe in the back, and
Mhm,
how that connective tissue and fascia is restricted as well. And it's everything interconnected, and the visceral connections of the diaphragm. It is how our organs maintain health with breath.
mhm,
And when the diaphragm
really.
descends, we're moving our internal organs, and our internal organs need movement to be able to be healthy.
Indeed.
And you can't bend forward if your liver doesn't go backward. If we look at a joint, it's the same thing, right? One's
Mhm,
back, the other's moving forward. The diaphragm and internal organs have to function the same way.
right.
That's how we have normal, healthy movement patterns. And if the diaphragm is not in a good position, if the zone of apposition is narrow and the rib cage is wide, we don't have a good pressure system. And
Mhm,
that pressure system, then the response to intra-abdominal pressure of the multifidi of the pelvic floor, even the glottis is changing.
right.
So for me, the diaphragm is the connection from top to
Yeah.
bottom and,
For sure.
and it interconnects everything we do. And so that's what I'm going to talk about. And I'm going to give some quick, easy assessments of how to check this function
Oh, great.
at the conference, because it's really, we need quick and easy.
Yeah,
We need something that we can do a quick go-to, a quick assessment to say, I need to look further here.
right.
Is it, do I have a ring out of place? Is it because my sacrum and ilium is out of alignment? That's causing pulling in the back, causing flaring of the rib cage in the front. So we need these assessment tools so we know where we want to go next and who to refer and how to.
Indeed. Well, that's wonderful. I'm excited all over again to hear about this. Can't wait to attend. So again, for those who are listening, it's June 27th, 28th, 29th in Denver. We do have the next day on the 30th. It's the Monday. We have dissection, right?
Dissection is right after.
Right after the post workshop. So get
Mhm.
in now because there's limited spots in the dissection. They're going fast.
They're going fast. Yeah. So I got my spot.
Yeah, that's good. And it's with Laurie Nemitz is conducting the dissection. She's
He's
very well
amazing.
known. And she's
Mhm.
amazing. She's an author. And so we encourage everyone, physicians, physical therapists, physiotherapists, as they
Yeah.
say in Canada and other places,
Yeah.
and allied health practitioners. You're all invited. We had our first summit last year, was a smashing success. That's why we're doing another one this year, focusing on the cervical, thoracic, shoulder. Did I get everything there?
Yep.
Those regions pretty much. So,
And
uh, yeah, go ahead.
I encourage people to be able to feel comfortable speaking with physicians. And,
Yeah.
they want to hear from you. I know they're busy, and just I can't tell you how often I've spent more days with Dr. Mazzola and uh, Phil, Dr. Steele, but when I was learning all the things I've been learning over the years, I'd spend a day in at least a day. And it was when I owned my practice, I would make it a requirement that the staff would have once a quarter, they'd have to spend a day with a physician, or at least a half a day.
Hmm.
It
Hmm.
was a quarterly requirement. And then you can really get to know your referring providers, and they can get to know what you know. They don't
Right.
know what we know, and they're not going to if we keep this separate. And being
Yes.
at C3, you'll learn to be how to communicate best with physicians so that you can feel comfortable to approach and speak to them and learn from them, and then they learn from you too.
Thanks so much for those inspiring words. Again, if you want to check out, it's collaborativecarecollective.com. So go to that website. You'll see all the speakers. You'll be able to read all about the description of the whole philosophy and theme and the courses, and you can register. So is there anything else? Do you have any contact information for anyone to train with you, either online, in person, or to see you as a practitioner? What's available? Anything?
Yes, I'm at Summit Pelvic Health. It's just summitpelvichealth.com in
Okay,
Frisco, Colorado. And it's in the mountains, beautiful place to come visit. It's
wonderful.
here. And so that's the clinic that I practice out of. And I teach a lot of courses on pediatric pelvic health. And that's with kidsbowelbladder.com.
Wonderful. Thank you so much. Okay, Don, you can stay after this call ends with me. I'll just end the call now. Thank you so much for your time, Don, and your wisdom, all your experience. And yes, it was very inspiring to speak with you today. And
And and when
if
are we
you're
interviewing you?
with that,
And when are we going to interview you?
yeah, we'll have to work on that too, right? Someone has to interview me and my wife and I, and Chris Frederick will be presenting a lab on dynamic stabilization of the shoulder, all the things we can do too with closed kinetic and open kinetic chain, a lot of closed kinetic chain, integrating with all the speakers with what they're talking about, right? The whole body. So collaborativecarecollective.com,
Mhm.
register, and we want to see you there. Take care, everyone. Thank you. Bye-bye. Thank you, Don. Bye-bye.